Hi, everybody. Welcome to Care Beyond Profit Conversations in Reimagining Healthcare. I'm Malini, Senior Director of Healthcare Organizing at the Action Center on Race and the Economy, otherwise known as ACRE. The Care Beyond Profit series highlights financialization in healthcare where profits and profit-making strategies, increasingly becoming more complex, are prioritized over delivering quality and equitable healthcare for all. Let people in here. This financialized healthcare system exacerbates and reinforces the structural racism in our country and in healthcare. We know we can do better, and that is what we are here to discuss. We'd like to thank the Robert Wood Johnson Foundation for their support for this series and their work to address healthcare financialization. Today's program is with Physicians for a National Health Program. PNHP is an organization of physicians who full-throatedly propose a publicly funded, nonprofit, single-payer health program. As state healthcare budgets come under increasing pressure from federal cuts, scrutiny around the role that insurance corporations play in Medicaid has intensified. In November, PNHP released a report called Removing the Middlemen from Medicaid, showing that removing insurance corporations from Medicaid and returning to state-administered programs could save a whopping $34 billion nationally and improve care. Modeled after Connecticut's successful deprivatization of Medicaid and drawing on the experience of several states, the report explores some common misconceptions about the role of insurers in Medicaid, the benefits of removing them, and then the paths to return management to state administrators. Since this report came out, legislators in a half a dozen states have introduced legislation to deprivatize Medicaid or are developing other reform efforts, and we will discuss that today. So we will share the report with folks in the chat shortly. And I want to introduce today's presenters. We have PNHP Board Secretary, Dr. Ed Weisbart. Dr. Weisbart is retired from family medicine and was Chief Medical Officer at Express Scripts. We have PNHP Policy Chair, Dr. Stephen Kemble, who is retired from the private practice of psychiatry and worked as a psychiatrist embedded in a hospital-based primary care clinic, serving a mostly Medicaid and uninsured population. And we also have Dr. Alankrita Olsen, who is a preventive medicine physician who joined the single-payer movement through the PNHP student arm, SNAP, as a first-year medical student. As a medical student, she organized SNAP's racial equity campaign and a successful campaign to move the American Medical Association to withdraw from the insurance industry's largest anti-healthcare reform coalition. Dr. Olsen joined the board in 2023 and serves as co-chair of the membership committee. So I will turn it over to you folks, and I just want to remind folks that this conversation is being recorded. So please, be mindful of that. And if you have questions, please drop them in the chat. Once the presentation's over, we will have a conversation, but if you have clarifying questions, please put them in the chat. All right. Take it away.
Thank you so much, Melanie. Thank you, everyone. Welcome, and thank you for joining us today. We have a slideshow that we're going to start sharing. Perfect. So my name is Alankrita Olsen, and I wanted to start off by providing some background on our organization. We're a physician-led nonprofit that has been around for about 38 years with the explicit mission of establishing a nonprofit, single-payer national health program in the United States that would fully cover medical care for everyone in this country without profiteering. So that's medical care, behavioral services, reproductive care, long-term care, everything that encompasses staying healthy. As physicians and researchers, we originally focused on bringing the data and evidence for a single-payer program to the public. But knowledge alone does not change minds, as we know. So we have grown as an organization. Next. In the past decade, we have started to undertake direct advocacy and activism around single payer and healthcare justice by building local chapters across the country. Next, or keep clicking through. Yeah.
Okay.
Building local chapters across the country, supporting medical students, working in coalition with similar mission-driven organizations, and getting into good trouble when we can. So we have really started to turnover and create more advocacy and activism around our message and hope for a single payer system in this country. And while we hold single payer as our true north, we have also been advocating for removing private insurance middlemen in public health insurance schemes, Medicare and Medicaid, to protect access to care now and demonstrate that corporate control of healthcare is bad. So under this current administration, we know that our bills for single payer, improved Medicare for all in Congress will not pass. For that reason, we have focused on local advocacy, specifically improving Medicaid. So today we're going to speak to you about our campaign for removing managed care from Medicaid, why we chose this target, the considerations for this effort, local efforts that are currently ongoing and upcoming, and hopefully encourage your organization to join the fight. Next. So Medicaid is essential. We know this. It insures 71 million people, including pregnant women, children and families, people with disabilities, and the elderly. Medicaid supports the overall health infrastructure by funding safety net hospitals and rural hospitals, as well as long-term care facilities. So in these ways, Medicaid stabilizes healthcare for entire communities. And as you can see in the graph on the right, most beneficiaries are people of color, so it is an essential service for communities of color as well. Next. Yet we have seen corporate takeover of this essential public service. And while this first graph shows you how private insurance middlemen have slowly taken control of our Medicare funding, you can see that it has actually been escalating at a far quicker pace for Medicaid, with 78% of Medicaid beneficiaries now under a managed care organization. And what does that mean? It's a private insurance company, so your Aetna, your United Healthcare, which receives Medicaid funding from the government to administer these benefits to eligible individuals. However, such a system emphasizes the wrong outcome, profit. Next. And this is most apparent when you consider the massive increase in the number of administrators within our healthcare delivery system versus the number of physicians who actually provide this care. So this is your insurance and hospital CEOs, 2 billers for every physician, and the numerous middlemen whose sole purpose is to erect bureaucratic hurdles and barriers to care. Next.
I think that's me.
Mm-hmm.
Okay. Good. Hello. And thanks again to Acre for inviting us. You guys are terrific. And thanks also to People's Action for putting this seed and fire in our craw. I mixed about 3 metaphors there, but thank you, People's Action, for putting this high on our radar, and thanks to Acre for helping us promote this and all the other great work Acre does. So I thought I'd spend a few minutes sort of explaining, so we're all on the same page, of what Medicaid actually is, how it works in structure, how managed care intrudes into it, and then we'll talk more about actually our report and how we came up with this enormous financial savings opportunity and why that's so important for our advocacy work. But first, here's what Medicaid is. As most of you may know, it's a combination of a federally funded and state funded program. So the amount of the ratio of federal versus state funding is different in every state. And it changes actually a little bit from year to year within parameters. But in general, across the country, the federal program, Medicare, funds 2/3 of the Medicaid program for the states, and then the states in general fund the other third. So those two funding sources go together or blend together within the state administered or the state's Medicaid program. So the state gets funding from both, and then the state owns essentially the Medicaid program, has to perform for that within certain parameters that the federal government sets as criteria for getting their funding. But there's a tremendous amount of leeway beyond those basic criteria from the federal government. So Medicaid in Missouri, where I live, is very different from Medicaid in Illinois, where Ken lives, or it's different in state to state pretty dramatically. But it's housed in the state, and then the state then then pays. Patients go to see their doctors and hospitals and pharmacies, perhaps, and then the state, of course, pays for that through this funding stream. Not quite that simple, but that's essentially how Medicaid was originally set up back in 1965. Almost that simple as this cartoon, and it is no longer that simple for the most part, as you saw from Dr. Olson. It's now nearly 80% around the country has managed care organizations or insurance companies interposed in between the state-run program and physicians and hospitals and indeed patients. So the funding source remains the same, 2/3 federal and 1/3 state with variation. But then rather than having the Medicaid program pay the physicians and hospitals and pharmacies directly, when they have allowed these insurance companies to interpose themselves, then instead the state typically prepays the insurance company, and the insurance company is expected to then pay doctors and hospitals. But of course, the insurance company then has the money in their bank account. They're prepaid, and they view it as their money, and they have all kinds of techniques to make sure that it stays that way. But in theory, they then pay doctors and hospitals directly on behalf of the state Medicaid program. So it's not quite that simple because the insurance companies are very selective. They say this doctor, not that doctor, this hospital, not that hospital, and they're each different. So a state may have anywhere from 3 to 10 different insurance companies interposed in this way, and then patients have to know which one of these they're signed up for, so they know which one of the networks, so to speak, they can go to. And it's a very complicated system that's designed, I submit, to block care because the insurance companies like not having to pay for care. So there's those barriers on that end. But then on top of that, there's the barriers that the insurance companies impose in between patients and their physicians and hospitals. Their rampant use of prior authorization and various other tactics that we've grown familiar with I'm learning about in Medicare Advantage, not today's topic, but they're more prevalent, if anything, in the Medicaid program. So what we're proposing, of course, is to get that the heck out of there, get rid of these middlemen. They're not adding any clear value, and our report shows a lot of ways that they're really actually damaging. So we propose really getting rid of them and going back to the state-directed program, the state-administered program. It's important to note that this isn't as heavy a lift as it may sound in terms of wanting the state to develop that competency. In general, across the country, most states, despite 78% of Medicaid patients being in managed care today, it's not 100% because almost every state has held back their aged, their blind, and disabled populations from the insurance companies. So they currently administer the Medicaid benefit directly, perhaps with their own care management sources and other things, but they directly manage the Medicaid program for their aged, blind, and disabled patients, which, remember, are the most complicated patients to take care of and the most expensive patients to take care of. And I imagine from the insurance company's perspective, the most expensive and the least profitable, perhaps, but also the most fragile. So goodness sakes that it's not involved in managed care, that managed care is not involved there. But our proposal is to simply take that existing infrastructure and ramp it up in a variety of ways. And I believe Dr. Kemble is going to unpack a variety of choices on how they could do that. But get the insurance companies who are trying to make a profit off of this, get rid of them from this. So the first, we're doctors, so we, of course, are interested in this because we see the direct harm that insurance companies introduce in their role. But we also try not to be too terribly naive and know that state legislatures are perhaps interested in that, but they're even more interested, perhaps, in the fiscal implications of what we're proposing. And indeed, although we've been alarmed by the impact of managed care on these programs for years, it's really just the last few months, the last year since the 2025 Budget Reconciliation Act, that there's an even dramatically greater intensity of focus by states to talk about this. And indeed, when Malini said that the country could save $34 billion, that's what the states added up could save. But remember, the federal government pays a good part of this. If you add in the federal savings, It's actually $77 billion that the country would be able to stop spending on healthcare. And I'll show you data suggesting to improve health, not worsen health. So $77 billion actually for the country. Hard to know, is that a big number or a small number? These numbers are so big. It's a big number, even for the federal government, even for the country. If you think about it, the 2025 Budget Reconciliation Act that caused the budgetary shutdown was cutting 1 trillion more or less from Medicaid over 10 years. I'm not a good economist, but a trillion over 10 years is like roughly 100 million or 100 billion over 1 year. And we're talking about 77 billion just on this one thing. And we have reason to believe our estimates are very conservative and cautious. We've had people tell us it's actually much larger. So how did we come up with the numbers that we did? We tried to be very cautious. We started our calculations using data that's public domain, published by Middlemen, one of the globally most respected actuarial firms. And Middlemen has studied the cost of managed care in Medicaid for the last 10 years. And according to Middlemen, managed Medicaid companies have a 13% overhead. 13% overhead, and most states have a state-run overhead of 2 to 5%. But so 13%, if you just pulled them out, we viewed that as sort of the baseline savings, and then we said, yeah, you would probably have to see some increase in the state administrative expenses, not as much as you might have anticipated. Actually, there's tremendous administrative load for states having to just manage and oversee the managed care industry. So there's tremendous dense regulations on that, huge expense. So states spend a fortune on that today. They would not have to keep doing that. They would have to do some other things, some other functions that the MCOs do for them. But our estimate is that anywhere from a 0 to a 2% increase in state administrative savings. So we took our 13% from Middlemen, and then we said, well, really, it's more like 12% because you have to put in some new state expenses. But managed care organizations are supposedly doing care coordination and improving clinical care and all this, and there's just no compelling evidence that they're succeeding at that. And instead, the states that have done this have shown better care outcomes. A good, easy way to think about that is that when one state in particular did this, first, they saw a 33% increase in the number of physicians who agreed to participate in Medicaid in the first year without having to increase what they were paying physicians. So they saw a 33% bump up in the number of physicians participating because we want to take care of patients and we want to take care of people who need healthcare, but we can't stand dealing with the managed care companies. So quickly, when you pull the insurance companies out, physicians say, let me in. I don't need a whole lot more money, but let me in and I will take care of these people. And it turns out if you have better access to primary care, you wind up having the ability to do earlier care and avoid emergency rooms and hospitalizations. And that's indeed what we've seen. There's compelling evidence that just doing this will wind up in a dramatic clinical savings, improving care, and that has financial value. And we believe it's a fair estimate to say another 5% savings for the state if they do this program the way we would propose. So the net savings to a state's managed care budget is as much as 17%. And we have had others make estimates recently after our report came out saying that we are actually significantly underestimating the financial savings. Have nobody say that we are overestimating. So these are very conservative, cautious numbers. And it adds up, right? So our report has detailed projections. You can't read this. The point is that there's a lot of detail. So there's detailed projections for every state about how much we think the state could save. And just to give you 3 examples, Florida, we estimate, could save up to $1.3 billion a year. And these savings start to accrue quickly. The state of Pennsylvania, we estimate, could save up to $2 billion a year. And New York would save up to $4.4 billion a year. And remember, these are low ball estimates, and these numbers by themselves, even at this low ball, are meaningful. But yeah, so if you add it up, almost every state, we're talking about hundreds of millions of dollars for states. My state, Missouri, it's about $250 or $260 million. So most states are hundreds of millions of dollars. And how fun is that to be able to go to your state legislature and say, hey, I've got this healthcare reform thing that will dramatically save your state money. It will stabilize your budget. It will prevent and it'll we're here as physicians to tell you it'll improve the health of your community. So it's been enormous fun having this. If you add that up, as Malani said, around the country, the states would save, if they all did it, they would save 34 billion in 2023 dollars. Federal government another 43 billion. So combined, it's real money even at the state level. But one state that did this, Connecticut, was the first poster child for it. They did it in 2012, and I believe Alan Creed is going to talk a little more about it. But they started this in 2012, and they immediately began reducing expenses, and they've saved billions. Their report propagates out to $4 billion of savings for tiny, tiny, tiny little Connecticut. So it's most states are bigger than that. So big money. But we are physicians. That's not our primary focus. Our primary focus is on clinical, and our report is jam-packed with lots of clinical data points. Here's one that looks at early stage cancer diagnosis. As you know, cancer is something you want to get in front of as quickly as you can. So it tends not to be something that's easy to diagnose in early stage, and it tends to be kind of this stable pattern. So New Jersey, which has a lot of managed care in their Medicaid program and didn't do anything to alter that, has had this level of early stage cancer diagnosis. Connecticut, however, eliminated managed care organizations, as I sort of alluded to you there, in 2012, and had a profound impact on the ability, quickly, on the ability of people to get their cancer diagnosed early, which is really life-saving. And there's a lot of other data points in the chart for you. So we propose removing the insurance companies. States don't have to do that. With the budget crisis, they can do other things. They can do what we're proposing. They could instead just decide to kick even more people off of Medicaid. Please, please, states don't do that, but they could. They could decide to cut benefits and cut services. For example, pharmacy is something that most state Medicaid programs include today, but the federal government does not require states to cover pharmacy at all in their Medicaid program. And there's a long list of other things that we take for granted, but that states could deal with their budget crisis by not removing managed care organizations, but instead by eliminating services like pharmacy or some home health services. Or they could decide to pay doctors and hospitals less. I'm retired, doesn't matter to me, but they could do that. And remember how hard it is for most Medicaid patients to find a physician who is willing to accept Medicaid reimbursement rates today. So states decide that they're going to deal with this by lowering what they pay physicians from the already generally low level. They will drastically worsen access to patients. So that's a dreadful choice, Or they could take funding from roads or schools or any of the other programs that states do. That's a terrible choice. Or they could raise taxes. You decide if that's good or bad, but they could also raise taxes. So we're giving them a choice that doesn't require them to do that. Let me turn it over to Dr. Kemble, who will be telling us about more specific strategies. Steve, you're on. And you're muted.
Hi, I'm Steve Kemble. I'm in Hawaii. I'm the chair of the PNHP Policy Committee, and we have been pushing for a bill to deprivatize Medicaid in Hawaii. I think that the idea of deprivatizing Medicaid is an especially good strategy right now because, first of all, Medicaid is under state control, unlike Medicare and unlike a lot of other things in healthcare. The states actually can design whatever system they want because they control how Medicaid is set up. And because we have the pressure of the impending federal Medicaid cuts, so that this is a time that we can really push for this. And once you get the managed care companies out of Medicaid and demonstrate that it truly is more cost effective, that gives leverage to expand deprivatization to other areas of healthcare. So in order to get somewhere with the campaign, you need to draft a bill so that you can offer something tangible. You can tell a legislator exactly what it is you're talking about. You can tell doctors what the implications would be for them, and it's tied to specific wording in a bill. So the first thing you need to do is draft a bill. And PNHP has several examples from different states, including the one we drafted in Hawaii this last fall, and more are coming. Next. Then you need to publicize, distribute, and discuss widely. Try to activate physician groups, state medical societies, specialty societies, publicize, talk to legislators, talk to their staff, op-eds, talk shows, petitions. Next. For legislators, you want to emphasize the cost savings for the state and expose the problems with managed care plans. There are things like blatantly false network adequacy reports. One of our managed care plans in Hawaii claims network adequacy of 22 patients for every primary care doctor, or a primary care doctor for every 22 patients. If that were true, every single doctor in Hawaii in all specialties would be doing nothing but doing primary care for that company's Medicaid patients full-time and nothing else. And the reality on the ground is you can't find a doctor outside of federally qualified health centers and hospital clinics who will accept any of the Medicaid managed care plans. So the network adequacy is blatantly false. So you point that out to legislators. Misleading financial statements. They misclassify much of their expenses as healthcare when they're really administrative. States often completely fail to provide any meaningful oversight of the managed care plans. Once the Medicaid department contracts with managed care, they only want to talk to the plans about their performance. They accept whatever misinformation the plan gives them as the truth and think that they're doing a great job, and the whole thing is completely disconnected from what's happening on the ground. And also that managed care literally drives doctors out of Medicaid. At least in Hawaii, when I started practice in 1985, Medicaid paid about 2/3 of commercial rates, and yet all the doctors in Hawaii were willing to take some Medicaid. When managed care came in, they all quit taking new Medicaid patients. And it's become a complete two-tier system where it used to be pretty well integrated. So anyway, these are all things that legislators need to know. And then you say, if you get rid of the managed care companies, it makes Medicaid much more attractive to doctors. You can improve physician participation, you can improve access to care, you can lower emergency room and hospital costs, and you can achieve these kind of financial savings that Dr. Weisbart clarified. Another thing is that Connecticut did it in less than a year. And the reason it can be done quickly is either, as Ed says, the state may be funding part of Medicaid directly, or even if they're not, you can hire, and Connecticut did this, you can hire one of the former managed care plans as a non-risk administrator for about 1/5 the administrative overhead of competing managed care plans. And that plan, having been a former managed care plan, has all the administrative structures already in place and can hit the ground running from day one seamlessly. So if you either expand your own state's direct administration or you hire one of the former managed care plans on a non-risk basis, you can get it up and running very quickly. For doctors, I'm just going to read the preamble to a petition that I drafted that this is a message that I found really resonates with doctors. And I've gotten a lot of support from both the Hawaii Medical Association and from several specialty societies. So what would be your level of support for a bill, which in Hawaii is SB 3306, that would terminate Hawaii's Medicaid managed care plans and replace them with a system that designed primary care practices, designated primary care practices as the managers and coordinators of care instead of insurance plan? SB 3306 follows closely what Connecticut did in 2012. Eliminating managed care plans saved 13% of the Connecticut Medicaid budget up front due to eliminating the high administrative costs of competing full risk plans. And Connecticut used some of the savings to increase primary care pay, add a care coordination fee for practices designated by a patient as their locus of care coordination, and added more community-based resources to assist primary care in managing high-risk and special needs patients beyond the doctor's office. The result was 33% improvement in physician participation in Medicaid from the first year, and improved access to care was followed by declining ER and hospital costs At 5 years out, Connecticut was spending 15% less per beneficiary than in 2012, along with 97% physician satisfaction with the Connecticut Medicaid program after it was deprivatized. That is incredible. Implications for physician practices include eliminating the managed care plan's incentive to impose excessive prior authorizations, limiting them to just a few services prone to abuse or misuse, use of fee-for-service. When you eliminate managed care, all you need to do is cancel your Section 1115 waiver that allows Medicaid to contract with managed care plans and go back to original Medicaid as a fee-for-service program, which does not require any permission from the federal government or from CMS. You just cancel the 1115 waivers. This is what Connecticut did. So then you go back to fee-for-service, but you improve it. And use the fee-for-service does not push risk onto physician practices, so it eliminates the administrative burdens and costs imposed by so-called value-based payment. There's no detailed documentation and data reporting required for risk adjustment, no linking of diagnosis to payment, no incentive to upcode, and returning the focus of documentation to patient care priorities and not gaming the billing system. Quality improvement projects could be funded separately with no quality metrics tied to payment. You give that to doctors and they say, sign me up. There's also the possibility of, if you can't get a bill through, since Medicaid is administered by the administrative branch, you go straight to the administrative branch and try to give them this data and persuade them to do it. And if the state has not previously passed a bill requiring that state to do it a certain way, the administrative branch can just change Medicaid because it's under their authority. So you don't necessarily need a bill. Back to Krita, right?
Yes, thank you. Now, while we use Connecticut as an example to examine the benefits of removing managed care companies, there is another reason why Connecticut is so impressive. Next.
Sorry.
As the private insurance capital of the world, with more headquarters in Hartford than anywhere else, it's surprising, but also empowering that they were able to achieve this feat. And really, it took a lot of strong local campaigning, educating legislators and communities alike about the failings of MCO to build a strong base of support, building coalition between different health justice groups, and keeping the pressure on legislators up constantly to make it happen. And as Stephen said, they were able to achieve this in 1 year after doing a lot of work beforehand and really building support, raising awareness, and getting ready to keep the pressure on their legislators. Next. So as we said before, People's Action was instrumental in bringing this idea to us. And since we've produced this report, our local chapters, People's Action local affiliates, and other healthcare justice organizations have come together to build campaigns and even start legislative processes to remove Medicaid managed care organizations from their state Medicaid program. Many strategized and hit the ground running this year, with 9 states actively working on bills that have been or will be introduced during their state's legislative session. PNHP is working with many different organizations in this effort, as highlighted throughout this slide. For example, Minnesota was the most recent, one of the first to start this effort, and their Healthcare for All is taking the lead, and they started in 2023 with a bill to conduct a study on how they could actually administer Medicaid without MCOs, and with the results of that study, they're ready to introduce a bill actually making that change. I'm currently in Maryland, and we are working with Progressive Maryland, a People's Action affiliate, and we've decided to go the same route in introducing a bill to study administering Medicaid without MCOs. And actually, we had our hearing yesterday that I testified at, and it's looking very positive. There was no opposing testimony. It seems very likely that it'll pass the House and hopefully through the Senate. And once we have that report, we're also, which hopefully unsurprisingly demonstrates the money we will save, we will also push for a bill to remove MCOs. Illinois, where the People's Lobby is taking the lead, is working on a bill and dealing with some back and forth with sponsors on the language. In Ohio, thanks to the work of their Single Payer Action Network, they have a Republican representative that plans to introduce a bill this year. And really, this strategy works across the political spectrum. With the federal cuts and Medicaid being state-run, it is in everyone's best interest to preserve access for the constituents. So this really reaches across the political aisle, and people really understand and believe in this material improvement that we can make to healthcare. I'll let Ed and Steven speak about the efforts within their respective states.
Sure. Yeah, I'll go first. In Missouri, also known as Missouri, where I live, we have a Republican veto-proof majority in both chambers and a Republican governor. And we were advised that going through the statutory process would be extremely difficult in our state. We weren't able to find anybody on that side of the aisle who wanted to be a sponsor this year for it. But it turns out that we're one of the states Stephen alluded to that does not actually have any statutory obligation to include managed care in Medicaid. Indeed, we introduced managed care into Medicaid without statute. We introduced managed care in Medicaid here and grew it entirely through the budgetary process. So, and our budget is in crisis, as many states are. Ours is in, deep crisis. So, yeah, we've been going, members of PNHP and a few other folks, frankly, with the deep coordination provided by People's Action locally here, known as Jobs with Justice, have been going to the state legislature. We went there Wednesday, and spent time with 9 different legislators, with I think 5 Republicans and 4 Democrats, who were instrumental people in the chambers, and people whom I've tried in the past to speak to who have not been eager to talk about some of the things we wanted to talk about. This time, we'd go up and say, "Hey, we can say we have an idea that can save the state $250 million quickly, and as physicians, we're telling you it'll make people healthier. So we got your back on this." People who have really surprised me have been putting their arms out and bringing us in and just dragging us into their office and sitting down with us and demanding more information, wanting our reports, wanting all this. And we're still pretty early, but we're really encouraged. We're really encouraged, and we have more meetings with them coming up next week. There's one legislator who actually thinks Medicaid and Medicare should be shut down by the federal government. And yet, there's this little window of common ground where he agrees with getting the insurance companies out. So we have to watch for what other perversions could be coming up on the road. But at the moment, we're finding common ground with brand new allies, and it's really exciting. And our members are getting invigorated. Instead of just talking to them about, what looks not easy to move forward at the federal level during the current structure, they're seeing pathways here, and we're getting members who have been not as engaged for a while, waking up and hopping in and jumping in and making the drives and doing stuff. So it's really an exciting, invigorating, motivating time to work on this. Steve, what's going on in Hawaii?
Okay, I got involved with 2 organizations here in Hawaii. One is the Democratic Party of Hawaii Health Committee, which helped me draft our bill. And we did that around maybe this past fall, September, October. And we also worked with a couple of the more progressive legislators in the House on the wording of the bill. One of them, both of them adopted our bill basically as we wrote it after some editing and getting feedback from others. So, and we got the chairs of the committees to introduce the bills. Our legislative session started in mid-January, and it's pretty compressed. It only lasts about 3 months. So even though we got the bills introduced, we got a bunch of co-sponsors, we were unable to persuade the chairs to schedule hearings. And they basically told us they weren't willing to consider anything that involved money, ignoring the fact that our bill offered them substantial savings. And basically, they didn't even read it because the objections they gave were not relevant to the actual bill. So we've got enthusiastic responses from everyone that we've talked to about it. Our efforts to publicize it have been well received, but getting a legislator to actually listen and hear the message has been very difficult. And Hawaii is a solidly blue state. We have a Democratic trifecta. but they're all tied to the status quo for various financial donor reasons from the insurance plans and things like that. So it's tough even here, even when you have a Democratic administration. The other group that I've been involved with is there's a Hawaii Physician Healthcare Shortage Task Force, which has about 90 people on it, mostly doctors, including all the leadership of Hawaii Medical Association and a bunch of people from the medical school and some representatives from the administration and and a lot of community doctors too, especially primary care doctors. And I have become actively involved in email dialogues on that, and that is where I realized that the message to physicians really works because they've endorsed our bill. They've said they would all support it. They would enthusiastically sign my petition if it were my survey if it were a petition. And I've been told by the Hawaii Medical Association executive director that there's a lot of interest in the proposal from Hawaii Medical Association. So I do think that we are building momentum. And now that the first crossover of the bills happened without us getting a hearing, our bills are dead this year. But we can still work directly with the administration and see if we can persuade the Medicaid department to consider this. We did meet with the Director of Human Services, which is over Medicaid, to say our previous director was hostile to us and she just retired. Could he please find a replacement who's open to this model? Look for people who were kicked out of North Carolina and Oklahoma who recently disbanded their primary care case management programs over the protests of their doctors because of political reasons, wanting to bring managed care in because they're Republican donors. But there are a lot of people that know the model, know how well it works, that we could hire as our new Medicaid director. That's where we are.
Let me say one more thing. We were taught by our arch conservative allies that some of our language needs to be a little bit more careful. So we started this whole thing by calling it deprivatization. And we were taught very, very clearly by some of our new allies that they like privatization. And so if we describe this process as deprivatization, they won't let us in the room. So we've shifted to calling it pulling the insurance companies out of Medicaid, pulling managed care companies out of Medicaid, going to direct straight administration, lots of other ways to describe it. But if you're trying to talk to some folks on the side that doesn't often agree with us, avoid the word deprivatization would be my advice.
Great. And that's not all. We're hopeful of three more states taking action this year. New York, Iowa, and Wisconsin have plans. And we also have a couple more that are starting the work of building a base. So creating a campaign, working to educate the communities, their legislators, creating partnerships, and coming up with a specific strategy for their state. But even with so many active campaigns, there are plenty more states that have Medicaid managed care. So it's important that we utilize this movement to join an effort or start an effort in your state. We have 3 more years before we can take the country back from this fascist regime. And in that time, we can transform our local communities and preserve healthcare access for so many vulnerable populations. So it's very important that we start thinking about getting ready for 2029. And in that way, being able to demonstrate that these private insurance middlemen are not necessary and corporate control of healthcare is bad will be our way to getting to single payer Medicare for all. Next. And each of us understands the power we have when we work together. And this is a great campaign that has brought so many different organizations into our sphere and can be an opportunity for you to work with other disparate local organizations and build power around a meaningful and material improvement in healthcare for your community. So we welcome anyone interested in getting involved or starting a campaign to reach out to our office and learn more. And we look forward to hearing about all the new efforts that we're going to start. We can take questions now.
That was outstanding. Thank you for really great research, sharing it in a way that was super accessible. It's just very smart research and smart organizing. I also want to, we should take questions, but if there's anybody from a People's Action affiliate or People's Lobby in Illinois or wherever, we'd also love to hear your experience with this on the ground, and that please add your voice. I know there were a couple questions in the chat. I think Lauren, I saw one. If you want to come off of mute and ask your question, that would be great.
Yeah, sure. Hi. Thank you so much for this presentation. I was sort of added to this, I think, by Martha Davis at RWJF. I'm also at RWJF. So just genuinely sort of, I don't know much about all of this, but just kind of thinking through if the care, the managing of the care is shifted to primary care physicians, and we know that varying states have varying amounts of those primary care physicians. What is the sort of cost burden, or what is the burden that's placed on these practices to be able to sort of coordinate all of this?
Steve, that's in your sweet spot.
Just a sec, I was putting something in the trash. I mean, in the chat. Excuse me. What was your question again?
No problem. Just sort of curious if um, the idea and the strategy is to move managed care to primary care physician practices, and knowing that those numbers of practices vary from state to state. What are sort of how do you sort of mitigate burden, cost, or time or otherwise on those practices to enable the best care for folks?
Yeah, that is a very central question. And one thing is that there are shortages of primary care doctors everywhere. They're severe in Hawaii. They're particularly severe in rural areas. And even if you get the middlemen out and save on administration, that doesn't guarantee access to care unless you get doctors who are willing to take Medicaid and are there in the places where they're needed. But I do think that the first step is you have to make primary care administratively simpler and attractive so that whatever doctors there are more willing to take Medicaid, and that if a doctor chooses to set up practice in a rural or underserved area, the practice will be viable and they won't have insurmountable administrative obstacles that prevent them from even considering doing that. And once you've cleared away the disincentives to practice in rural areas, then you need to, advertise that to medical students. I don't know how it is in other states, but in Hawaii, about 70% of our medical students say they wanted to go into primary care when they start out, and less than 10% actually end up doing so because they realize the economics just don't work here in Hawaii. Whereas if you could show them that the economics would work, a lot of them might stay wanting to be in primary care. But the ways that it would improve the practice environment are, first, directly raising pay, because some of the savings from administration Connecticut used to raise primary care pay. Second, they added the big ugly bill limits Medicaid pay to Medicare rates. So you can't go higher than that, but you can add a care coordination fee, which is a small capitated payment on top of fee for service for any practice who's been designated by a patient as their locus of care coordination. So you can add that and raise pay a bit more. And you can also add more community-based resources such as specialist consultations, where if a primary care practice has a patient with a complicated problem that they feel they can't handle on their own, instead of having to find some specialist who will accept the Medicaid insurance the patient has and will have the time to see the patient and is available in the area, which is often the answer is there isn't any such thing in all of those counts. You can call a community-based team with a specialist backed up by interdisciplinary group like nurse practitioners or nurses or social workers who will contact the practice, get a detailed history from both the primary care practice and the patient, present the case to the specialist who will then tell the primary care doctor what to do. And you can do all that over the telephone within a couple of days. And that would enable primary care practices to deliver specialty informed care anywhere in remote rural areas. And that takes a lot of the stress off of a primary care practice if that kind of thing were available. So those three things, improved pay, care coordination fee, and ready access to resources to back them up in managing care will go a long way toward making primary care practice viable and fun again.
Yeah, I think another aspect of this is to really emphasize that while managed care companies are called managed care companies and, allegedly improve care coordination, the reality is far different. They create these narrow networks where it becomes difficult for primary care providers to be able to actually help their patients get to specialists and see doctors, and the wait times are ridiculously long because of that. So I think it's very important to stress that care coordination is something primary care doctors want to do and should be doing, but it becomes difficult under the managed care organization model. And by removing that, when you have just one network of Medicaid doctors, it becomes much easier to coordinate care, for data and information to be exchanged, and for patients to be able to actually access that care.
One of our new surprising allies said managed care as a verb is a good thing. Managed care as a noun is a terrible thing.
Mhm.
Lauren, did we answer your question?
Yeah, that was helpful. Thank you very much.
I invite others to, Mary, would you like to ask your question?
Excuse me. I'm Mary Lou Henrich, and I am currently one of 9 members of Oregon's Universal Health Plan Governance Board that is charged with putting together the plan for universal health care in Oregon. Unbelievable task. Thank you, Stephen Kemble, for helping us out and also kind of being blocked by some of the leadership of the board. But I've become convinced, and we haven't really talked about this as the board, so this is my own personal thing because it's a big deal. I can't talk as the board. That one of the first things we do need to do is get rid of the managed care plans for Medicaid. It is, we have out of a 4 million population in Oregon, over 1.2 million are currently on Medicaid. 60% of all Oregon births are covered by Medicaid. So it's really a big deal here. And if we could go about and I'm seen as a traitor by some because I started Care Oregon, which was back in '94, one of the first managed care organizations, and they were all seen to be local, really had lofty ideals, and I do think for my 10 years there that's what we were doing. They're still mostly nonprofits, but not all because they let Centene in. And so things are, even getting worse. But still, it makes sense to me that if we could go back to just what you're talking about with 1 million of our Oregonians, it would be that first step that we can then get on to the broader thing of having this kind of plan for the whole state, for all of us. So anyway, I really salute all of you for this. I'm glad to get the report. And we need to, and I've had a couple of conversations personally with the leader of our House Healthcare Committee and also the Senate Healthcare Committee. We have a Democrat majority here, but still, as you described, some of you, that they're still very beholden to this idea that, managed care as a verb versus the managed care. I love that because it sounds really good. And coordinated care, ours are coordinated care organizations. So that sounds even better, like we're coordinating the care. It's not really happening. So anyway, just thank you. And we want to work together with you. I know Mike Huntington is very involved with you and is the one who connected me to be on this call today. So thank you. And let us know if there's anything we can do and let's work together on it.
You're welcome.
Thank you.
I have a question about prior authorization. And I know you mentioned how challenging it is for providers to deal with all the paperwork and all of the administrative tasks that they're burdened with. But prior authorization is something in particular that really affects patient care in so many ways. And I think in your report, you noted that MCOs, there's increased prior authorization, like there's increased denials. And I think it was in your report that even when physicians get the prior authorization, it's not necessarily 100% guaranteed that they're going to get paid on the other side of it. And so it just seems like that is just one of the worst consequences, in terms of patient care here. How would deprivatizing Medicaid administration relieve these problems with prior authorization? And I also, related question is, if a patient or a family sues a provider, and there's an MCO program, then does the MCO pass that burden on to the provider? Like, I just feel like they're related questions around like the care and prior authorization and who bears responsibility for all of these
I
problems.
could take a whack at that. So, I mean, whether there should or shouldn't ever be prior authorizations is an interesting question. Is there any need for prior authorizations in any circumstances? I don't know really the right answer to that. What I do know though is that prior authorizations are used by the Medicaid by the managed care organizations, not to drive physicians to clinical guidelines, as they claim, not to try to make sure that it's the right care for the right person at the right time. They're used specifically because these outfits are prepaid. They view it as their money, and anything that they can do to delay care means that they get a return on their investment in the stock market with the money that they have. And it means that they ultimately may not have to pay. And you're right, the implications for individual patients is enormous. I had a medical student actually Monday this week tell me that she's been on Medicaid most of her life. She didn't understand any of the issues of managed care, and she has pretty severe musculoskeletal issues. So she wanted to go to physical therapy. She was sent to physical therapy, and she was told she had to wait 3 months to get that approved. She waited the 3 months. She went into physical therapy and was only approved for one visit, and had to restart the process to get the second visit. And for some people, physical therapy, maybe makes them feel a little bit better, but for a lot of people, physical therapy is life altering. It's life altering. And so for her, she's really struggling. They do that because for two reasons. One, they know that they get that blockage of having to pay anything, but also they know they don't have to care because people are going to transition in and out of the Medicaid program. And if they delay care long enough, they're going to just not be in the Medicaid program. And so the consequences of hurting somebody's care and delaying that early diagnosis of cancer don't fall to them necessarily. So they've got a strong business model to screw this up for people. If you pull the insurance companies that bear risk from this out of it, that are often publicly traded, if you pull them out and just have the state manage it, the state's primarily interested in making sure that, of course, they stay within their budget, but making sure that people are healthier. So there's no profit-centric reason for a state to do the egregious prior authorizations. Should they do any? That's a different question, but they can do far, far, far fewer. Traditional Medicare has a few prior authorizations that they do, and they're for actually pretty reasonable things that they do it. Things that could be cosmetic instead of being medically necessary, for example. So there's maybe a place for some. I don't know the answer to that question, but at any rate, the current use of them by the insurance industry is profit-centric rather than care-centric. So that almost immediately gets fixed by this.
I would like to add that if we had what I described of an array of specialists available for telephone consults to primary care, they could determine medical necessity for any legitimate purpose and say, this patient, all you need to do is this, and you can manage it in primary care. That patient is too complicated. They need direct care with a specialist. We can help facilitate the referral. That would control determining medical necessity. You don't need any insurance company doing prior authorization to see if it's medically necessary or not. You let the specialist teams do that.
Krita, you're living and breathing this. Have you more to
Yeah, I
add?
mean, just yesterday, actually, we got, well, I was at the health committee hearing. There was a lot of bills around retroactive denials, both from the patient perspective as well as from the provider perspective. I mean, physicians don't have time to sit around and be told after the service has already been rendered, after something's been approved, and they're practicing evidence-based medicine, to be told by the insurance company that actually we're not going to pay for it. who's got time to actually call their AI system to be able to finally speak to someone to be like, why was this denied all of a sudden after the fact? And then patients, get the same thing. They're told after they've received therapy. And actually, one of the patients testifying was talking about a year after doing their physical therapy, they got a bill for $3,000 because the MCO, and it was a Medicaid MCO, retroactively denied that coverage. So it's crazy the bureaucratic ways that they have found to continue to make profit. And we keep on fighting this with every little step, like, oh, let's attack this retroactive denial. Let's do prior auths. When really as with single payer Medicare for all, by removing MCOs in total, we can improve the system much more.
Hank?
So an answer I came across talking to Canadian provincial physicians is instead of prior authorization, the Ministry of Health does retrospective review. So in other words, they know what everybody's ordering because they have all that stuff. And so they graph you in if you're more than 2 standard deviations out of the norm, you get a phone call and they're saying, gee, did you know, or you're ordering 3 times as many back MRIs as your peer group? And of course, then it's either education, I didn't know that, versus, do you know the guidelines? Oh, well, then get with the guidelines. And then it can also be like, oh, we also notice you write 5 times as many oxycodone prescriptions as your peer group too. Maybe you're actually running a back pain, dispensary, or anyway. So the idea is, and then it goes to the medical board to look at your practice. So instead of, some of the answers are, well, how are you going to control cost if you don't have prior authorization? Said, well, there's a better way. It's called retrospective review, and anybody who's out of the guidelines or out of the standard deviation gets a discussion. And if there's a lot of money involved, they actually the province asks for their money back. So,
Brilliant
Yeah,
answer.
that would also address like upcoding, like you're saying, or anything like that, like, right?
make sure
A
you're
good
within 2
caution.
standard deviations of the mean. That was the operative joke that got. So.
Other questions or comments?
Can I ask the group a question? We've been blathering quite a bit for the last hour. Is anybody in a state that you think has not yet started this sort of a campaign, but where you're motivated to go and try and build some bridges and get this to start happening in your state? Don't ask a question if you don't know the answer. I shouldn't have asked that.
Yeah, I'm in New Jersey, and we actually have a first meeting with an assemblywoman on March the 10th, where first person will present this whole idea to. We have a bill in New Jersey that actually would make Medicare available to every New Jersey resident. It's fairly unique, but that's obviously a longer term effort. So we see the deprivatization legislation as a way to kind of do something in the shorter term that's going to have a real impact. And so, this will be our first attempt. If she bites and she's interested, then we'll go from there.
It's exciting.
I'm with the New Jersey Universal Healthcare Coalition, by the way. So, and we're a statewide organization advocating Medicare for all.
In Maine, I'm on the board of the Maine Medical Association, and we have a subcommittee about healthcare reform. And we're running out of topics, shall we say, since we did our letter. So this would be something I'd like to have, again, Steve, maybe that letter, and present it to the group and said, let's present this to the Maine Primary Care Association, because it seems this appeals, first of all, to the primary care community, as it would simplify their life. And if it indeed then works easier for the specialist community because they get less inappropriate referrals, shall we say, from the primary care community, but more appropriate and refined referrals, they might like that better too. So if you can share some of that information or as work progresses, that'd be great.
The chat won't let me post it to the chat. So if there's maybe, Malini, if you can give me your email address or something like that, I can send it to you and you can send it to all the participants.
That'd be great. Thank you.
Okay, what's your email address?
I'm putting it in the chat right now in case anybody else wants to reach out to me. There we go.
Yeah, I see in the chat, Washington starting the effort, no co-sponsors. It's very important to start base building. Talk to physician groups, talk to Medicaid patient advocacy groups, get the support so that they can talk to their legislators and when they're hearing from their own constituents and they're seeing a push from it and their colleagues are hearing the same thing, getting co-sponsors and pushing the bill forward becomes much easier.
Other questions that folks may have? I just have a small question that you noted about. Oh, Mary, did you want to ask your question?
Mine again, it's not so much a question as this has really raised in my mind that on this governance board that has to put a report to the legislature in September on, actually the steps that we're going to take to get from where we are with, all of the mess in healthcare and insurance and all of that. It seems we will be putting together recommendations on stepping stones, things that could be, not one leap from here to there, but what would get us, moving in the right direction. And I really plan to pursue this with you and really look at this as one of those stepping stones to get it in the report. The report will go to both the healthcare committees of the Senate and the House. We have strong support for the overall idea of a universal health plan from the chairs of both of those committees. So this seems like, something like I said, if it's 1 million people out of our 4 million in our state, that this would be, but it's really going to be a heavy lift taking on those coordinated care organizations that have done a very good job over the last 20, 30 years now, convincing legislators that they're the best thing since sliced bread. And however, we've had a huge turnover in our legislature, and that can be good and bad. We've got a lot of new, young, progressive legislators, but they have really very little experience in how the game is played. And so some of them, I think, will be more open to this idea, but I'm not sure that the people who really long-term legislators who kind of run the place and have those same issues that have been brought up about getting money for their campaigns. Oregon does not have limitations on campaign funding. And so when you look at who's funding and who's down there convincing them that you don't want to change this, so it's not easy, but it really feels to me like it could be a real tangible first step. So anyway, you've encouraged me. I was feeling rather down this morning as I was out taking my walk, thinking, oh my Lord, what have I gotten myself into and in my old age here? But anyway, thanks for all you guys are doing. It's wonderful.
It is. It's very inspiring work that everyone's doing here. I just had a quick question about, you noted in the report about proprietary information, and it runs the gamut of everything from like payments to providers to health outcomes and profit and loss by insurance companies. Like people cannot, including legislators and state folks, are struggling to get information. And I didn't know if there is a strategy around that where it's like freedom of information requests or something that journalists, where we still have journalists, can start to push on these things, because that sort of opacity is both a problem for us in terms of developing our strategy, but also an opportunity to just show like people want the sunshine and the sunlight. And so I just didn't know if there's a thought around how to attack the proprietary issues.
Yes, the Connecticut effort began with a legal aid attorney, Sheldon Taubman, who noticed that a lot of his clients were getting screwed over by the managed care plans. And it took them several years of freedom of information requests, publicity, asking legislatures, that you're giving all your money to these plans and there's no accountability. You can't find out what they're doing with it. Doesn't that bother you? But it took several years of pushing on all those fronts before they got it over the line. But that's what you have to do. Sheldon Taubman is a really interesting guy. If you're in a state that's interested in this at all, he's quite willing to talk to you, to tell his story, or there's written versions of it that I have that are readily available. But his story of how they pulled it off is inspiring and very instructional. He was one of the co-authors of the report, the PNHP report also.
But no, you're definitely right, Melanie. That's one of our talking points in Maryland, definitely getting more transparency in financial and clinical decision making by removing MCOs and streamlining data availability and access. We have a statewide health information exchange, but a lot of information from MCOs has to be reported by them, and a lot of it is not, and there's very little oversight in making sure they are reporting that information. So yeah, it's been a great talking point in trying to get people to understand why the splintered version of a system with so many MCOs, and Maryland's a small state and we have 9 MCOs, doesn't serve anyone well.
Folks have any other questions or comments? I really want to thank our presenters, Dr. Olson, Dr. Weisbart, Dr. Kemble, and Ken Snyder at PNHP. This is actually fabulous. The report is really well written. If you have not read it, it is very easy to read. The information is quite accessible, and it's chock-a-block full of resources that you could just dive into on any single one of them, and it's a wealth of information. So please read that, reach out to folks, reach out to me if you need more information or you need to be connected with anybody. And I just want, we do these series monthly. And so I will reach out to folks with the next event in this series. We will have down the line Patients Union and Americans for Financial Reform, talking about medical debt, talking about how patients can have a healthcare union. So we encourage people to join that, and we will reach out to folks with those dates as well. And then I think we are done then. I don't know if there's anything else. This is amazing.
Yeah, I just want to mention in the report, Appendix 7, we actually break it down per state and provide you what your state can save. So being able to just that first number, that first bit of data that you can use in your advocacy is powerful.
And just to underscore that, you can be confident that those numbers are achievable. Everybody who's looked at that report since then, who has economic insight to details in their state, has said that our numbers are low. Our numbers are low. I have not had a single person say, "Oh, that's unachievable." Nobody has said that. So you can take our best case scenario as a very cautious conservative estimate.
One other thing about that is that the range of savings that is projected in the end of the report is what the low end is if you don't do any of the care improvements to enhance primary care, you just get the administrative savings. And the high end is if you include all those enhancements to primary care. But a state would be crazy not to implement improvements in primary care. And so if you were to include that in your bill, that those enhancements are part of the bill, then you can project the high end of the savings at least.
That's great. It's a win-win. Let's get it going. Let's win. Go out there and win these. Let's kick out the MCOs and have a better healthcare system. Thank you, everybody. Have a great weekend.
Thank you.
Thanks.
Take care.